This session is about anesthesia and pain management. I welcome you all in this session. We are delighted to have Professor Khalid Bashir as the chair of this session. We all know him well for his contribution and dedicated hard work for the establishment of pain medicine in Pakistan. He is a Dean of Faculty of Anesthesia, CPSP, Pakistan. Thank you, Professor Saab, for gracing this occasion with your presence. Our co-chair is Khwaja Shahryar Nasser. He is a consultant orofacial pain at Shaukat Khanum Cancer Hospital. He is a researcher and editor of Shaukat Khanum Journal, the Journal of Cancer and Allied Specialties. Dr. Khwaja Shahryar, we welcome you to this session. We have 5 speakers in this session, and we will take questions in the end. Our first speaker is Professor Bernard Frank. He is consultant pain medicine at Walton Center, Liverpool. He is also professor at Liverpool John Moore University. He is a clinical lead for neuropathic pain and opioid management. He will be talking about opioid management in long-term cancer survivors. Professor Bernard Frank.
Thank you very much for inviting me to the Cancer Symposium in Lahore. Thank you very much for inviting me to the Khanum Cancer Symposium in Lahore. This is the new outpatient department in the Walton Center where we host our pain management program and our outpatient clinics. And on the ground floor, I actually use a repetitive brain-navigated TMS device for central neuropathic pain, but this is a completely different talk. The change in opioid management has been necessary in the last 10 to 15 years. What I do with my colleagues, in particular nurses at the Walton Center, and how this came all about. And I'll give you an idea about the referring pattern to the Walton Center, how we run our opioid management clinic on an outpatient and inpatient basis. There are certainly some risk attached to the opioid management, and there are options of short and long-term opioid maintenance, which can be useful to achieve your primary goal in getting people off opioids altogether, or at least into a more safe range of opioids. The main reason why opioid management had to be changed in the UK was there were new regulations from NHS England who tried to convince GP practices and others to reduce opioids in non-malignant pain to an upper limit of around 120 milligrams per day, which is an arbitrary number, but there's certainly evidence that the risk of accidental overdose goes up above 90 milligrams, and there's certainly increased risk of side effects in patients who are even on more than 50 milligrams of morphine a day. But the main evidence or based reason for opioid reduction is actually the lack of evidence of opioids in persistent pain long term. That there can't be a simple answer for something like complex chronic pain. And obviously the prescription opioid epidemic in the United States, which was also a minor, lesser problem in Australia when I was there. So I got involved in quite a lot of opioid management during my training. And I'm going to show a few slides about the opioid prescribing trends in the UK. And there are certainly increased death rates in the UK as well, but more pronounced in America, where there are now more than 100,000 deaths per year related to opioid overdose from prescription opioid drugs and illegal opioids. So you can see on this slide that particularly oxycodone and fentanyl have increased significantly in the UK, but also morphine sulfate in the slow-release versions, which was partly due to a higher marketing drive from companies, which is particularly true for fentanyl, as Vioxx, one of the new OX2 inhibitors, was taken off the market, and there were a lot of free pharma representatives to hire who promoted fentanyl in rheumatology and GP practices for the use in chronic pain condition. There was certainly an increase of average opioid daily dosages, and the increase was predominantly in non-cancer pain. There's an increased cost to the NHS, but the structure of the NHS with a GP net service has certainly prevented significant problems as seen in the States and at the time in Australia due to lack of continuity of care, but unfortunately looks like the UK is heading in the same direction at the moment. The reason why I got involved, because I'm based in Liverpool and we have 3 of the highest prescribing CCGs, which are the kind of primary care networks who actually commission NHS services. So we are a big specialist neuroscience hospital serving 3.5 million in the northwest of England and North Wales. I started this in 2010, initially jointly with a addiction doctor, but this fell apart after the management structures. Nevertheless, I have written some opioid service specification, and after some fighting, now have a once-monthly joint opioid clinic with a clinical psychologist, and our opioid prescriber nurse is present as they need to know the patient before they take over the prescribing, but I have no addiction specialist despite several attempts to try to initiate it. We still do some kind of systematic titrations to see if patients are opioid responsive at low dosages. This is certainly helpful in conditions like neuropathic pain and simple pain, where sometimes you can see a significant benefit from low-dose tapentadol or methadone, but also from other opioids. So we have an administrator team, we have got advanced nurse practitioners with prescriber training, and we've got quite a bit of clinic time now to follow these patients up, as they certainly need some support to keep motivated during the weaning of the opioids. We have recently changed from a low-dose ketamine infusion protocol, which we started off for CRPS, but then extended the indications for opioid weaning and now headaches, and we have oral ketamine from our hospital pharmacy available for alternative pain relief. And I have obviously very well-trained nurses who help me during the admissions, and we are back to only one ward, so we can keep the training up to date rather than having patients over the whole hospital, which was necessary during the COVID pandemic. And we have one of the biggest pain management programs in the country, so I always have the option and start introducing this from the beginning to refer patients for a psychology-based pain management program, and sometimes this is very helpful to then finalize the opioid management by taking patients off. So the patients are referred from other pain clinics or other specialists, including our spinal surgeons who see patients on higher dose opioids before they do major spinal surgery, or we see patients from palliative care services with long-term cancer survivors in oncology who have started patients on this as part of their underlying cancer condition. I see mainly tissue referrals in the Joint Pain Management Program Assessment Clinic, and they are identified during this assessment on high opioid doses, and they are certainly better treated by doing this in the beginning rather than remedicalizing them after they have learned some pain management skills. I try to only see patients above 120 milligrams of morphine, as this is mainly a primary care problem, and they should try to attempt the lower dose morphine reduction themselves, but obviously if they have tried this and GPs give a good enough reason, then I'm happy to accept them from primary care as well. So the standard treatment would be on an outpatient basis, where we see them with a biopsychosocial pain assessment. Then we try to review why they are on opioids, if they're doing what they are supposed to do, if they have plenty of side effects. And usually patients are easily convinced that a reduction of opioids might be quite helpful, and they would also benefit by reduced pain, by reversing opioid-induced hyperalgesia. And as we have done nearly 1,000 patients now, I think we come across with some confidence that this is a good thing to do for patients. We aim for 10% reduction per week, and usually complete detoxification, but due to the nature of my patients, I think that's not always possible. If they struggle during the normal 10% weaning regimen, then the nurses can ask me to see them again, or I advise them just between doors, as the clinics are next to me. We try then some opioid rotation, where you can usually achieve a bigger drop than the 10%, as the new opioid blocks in a different way on the opioid receptors. And that can be done serial times between morphine, hydromorphone, and oxycodone, for example. We normally then add some oral ketamine after checking baseline LFTs, but I try not to commit to prescribe this long term. But there are some patients who really get good benefits from ketamine, particularly in headache disorders. So I have around 5-6 patients on long-term ketamine prescriptions. The best sort of alpha antagonist is probably clonidine. There is a licensed one called Fexadine, but this is not available in our formulary and quite expensive. So this is an equivalence table I have designed over the years to give you an idea how to convert the opioids in a morphine equivalent 24-hour dose, which is helpful to document the success of the weaning, and also help with the rotation to different opioids along the way. So this is from clinical experience, because there are a lot of conversion tables on the internet, which some of them are quite dangerous because the equivalence tables are wrong. And with methadone, we normally do a baseline ECG, and I have not seen any QT elongation at the low dose I use between 30 and 40 milligrams as a maximum per day. There are some different brands of buprenorphine patches, so if it goes higher than 40 micrograms per hour, then the patches need to be changed every 4 days. The ketamine we use is actually manufactured in an NHS hospital pharmacy, where they just mix preservative and certain different taste liquids, like fruit syrup with 10 milligram per mil IV ketamine solutions, and this seems to work in most patients, and has made it quite affordable, as one of the little bottles is around 20 pounds. The mechanism of analgesia is obviously different from the opioids, and unfortunately there is not much evidence from controlled trial, but we recently developed and validated an assay from the IV ketamine patients, so hopefully I can repeat this at one point and see if patients actually absorb this in any meaningful way. There's certainly a patient variability due to the poor bioavailability by swallowing the ketamine, so sometimes it can just be given sublingually if really needed. It's quite short acting, with a half-life of around an hour, so we have to give it quite frequently. Like I said before, I use a maximum of 200 milligrams per day, and try not to extend the use after 3 months for patients. But because they have something else to take, in particular replacing the short-acting opioids, that can be quite useful to keep them on track with their weaning regimen. I have been a big user of tapentadol in the UK, because I use this mainly as a step down when we had achieved something like 60 milligrams of morphine twice a day, as you can post-taper this by slowing down the withdrawal from the opioids, and if patients get some benefit from the second tapentadol, which basically increases noradrenaline reuptake inhibition and kind of enhances diffuse noxious inhibitory circuits in addition to the opioid circuitry, then they end up on quite low dose of morphine equivalent of around 150 milligrams of tapentadol twice a day, which is 30 milligrams of morphine twice a day, and they can usually come off this if they want to without further input from an opioid clinic or even the GP. I also use low-dose methadone, which is probably quite helpful in patients who respond to ketamine. I only use it again for a period of 6 months or so, as a lot of GPs are still quite opposed to prescribing this long term, and we would end up with a lot of prescribing patients. And the maximum is usually 5 to 10 milligrams 3 times a day. After they have been stabilized on this for 6 months or so, I often would try to rotate them to tapentadol overlappingly, and that seems to work quite well. On an outpatient basis, you can't really do this on any patient above 150 milligrams of morphine equivalent, but I try to get them down to 100 milligrams before offering this. We also use high-dose sublingual buprenorphine, which I have done a few times in an outpatient setting, but this is our main drug we use as an inpatient because it is very helpful in controlling withdrawal symptoms, usually on day 2 when the opioids are completely stopped the night before we start this. As the best effect is really when patients are in some degree of withdrawal already, and then they find this very useful. So in terms of outpatient activity, we get most of our patients down below the 120 milligrams of morphine equivalent, or we wean them off opioids altogether. Some patients have to be admitted as they struggle to do it on an outpatient basis, and I have then referred quite a few to the pain management program, and they managed to wean off the opioids altogether. One of the reasons why they have to come off this before the program is that they are usually quite sedated, and they need to be clear-headed to learn psychological skills in the pain management course. From an inpatient point of view, we have changed now the regimen from ketamine infusions really to sublingual buprenorphine as the first attempt in all patients, and I have not gone above 10 milligrams per day, which is much lower than the replacement treatment in veteran hospitals in the States, for example. And we have done 50 patients so far with quite high success rates. And I have to admit it was quite a steep learning curve in the beginning. Some patients don't want to go through a 4 months outpatient taper, and this can be done in a week with kind of probably an added 12 weeks to do the outpatient taper with buprenorphine, but this seems to be tolerated without too much hiccup in most patients. I do this as well if patients are from far away, because it is quite time consuming to communicate with this GP on a regular basis, and it takes a while for them to implement changes from letters in their primary care practice. Coming back to the risk, there's certainly a risk of inducing depression and unmasking mental health problems if you take patients of high-dose opioids. With methadone, we gave him after detoxification for his ongoing visceral pain. And I only want to highlight that this kind of opioid management in high-dose opioid patients is not without problems. But the main thing need to be prevention. So with my experience from Australia and what has been published in the literature now, and the huge epidemic of overprescribing of opioids in the US, I think we have recognized this quite timely in the UK. Important guidelines like NICE guidelines for low back and chronic pain have been changed and has been clearly stated that opioids are not indicated for this chronic pain management. We need to really educate our GPs, and hopefully can use some cost savings from the drugs and side effects of opioids, and implement more self-management programs in the community. And my hope is still that I can retire without having any patients left who need advanced opioid detoxification, as the GPs have learned not to escalate the dose into amounts where this will be necessary. So there is a trial going on at the moment, which we applied for as well in 2015, but the grant went to Warwick University. They reported results in Toronto. It was unfortunately negative for the primary outcome, but they have a lot of benefits in secondary outcomes, and looking at this study in detail will certainly be helpful to commission kind of primary care-based opioid management services in the future. So there are still a considerable number of patients in NHS on high doses of opioids that needs to be recognized earlier, as it's an easier to wean patients off rather than keeping them on high opioids for years, where it becomes quite problematic. And we are quite successful in doing this. Most patients feel much better when they have been off these opioids. And hopefully we can increase the knowledge and practice experience of doing this in primary care in the future. So thank you for your attention. And as I said, I'm happy to answer email questions if required.
As you see, the voice was not so clear. So just to give you a take-home message for the residents in Pakistan, that strong opioids are needed for cancer pain, but they are not available in Pakistan. We need to rely on available drugs, which are tramadol, codeine, and tapentadol. Only three are available. Buprenorphine was once available, but now it is again not available here. So we should rely more on neurolytic blocks or regional blocks to counter pain. And the good thing was ketamine, use of oral ketamine. I have been using that with paracetamol mixture, and it has been very effective. People keep on coming, give us more, till they die. So oral ketamine is very effective in our setup. Thank you for your attention.
Thanks to Dr. Bernard Shah and Dr. Khaled Bashir for summarizing this. Our next speaker is Dr. Sanjeeva Gupta. He is a consultant in pain medicine at for Teaching Hospital at NHS Trust. He is a elective board member of the Faculty of Pain Medicine. He is an author of many books and teaches at various eminent courses. His talk is about assessment and management of neuropathic pain.
And before I start, I would like to thank the organizing committee members. For inviting me to give this presentation. Neuropathic pain is quite common, as you all know, and it can be one of the main causes of distress and disability in a given patient. So we'll discuss about classification of pain, what is neuropathic pain, examples and causes of neuropathic pain, assessment and diagnosis of neuropathic pain, mainly focusing on clinical features, and then look at treatment of neuropathic pain in terms of pharmacological treatment, interventions, neuromodulation, and also think about prevention of neuropathic pain in the first place. Classification of pain, broadly classified as nociceptive pain, which is due to tissue damage or inflammation, which you see on a day-to-day practice, like postoperative pain, headache, back pain, and other types of pain. Neuropathic pain is pain initiated or caused by a primary lesion or dysfunction of the central or peripheral nervous system. And nociplastic pain is pain due to activation, amplification, central sensitization of the somatosensory system. In terms of treatment, I think we will concentrate on neuropathic pain today. And patients can have mixed pain. They can have nociceptive pain and neuropathic pain. Say, for example, if a patient has low back pain, the pain in the lower back could be nociceptive pain, and the pain shooting like an electric current down the leg to the toes could be neuropathic pain. So we need to address both types of pain. For that, we need to understand both nociceptive and neuropathic pain, but today's focus will be on neuropathic pain. The incidence is quite high. Nearly over 25% of patients attending the pain clinic can have neuropathic pain. Again, in diabetes, it could be 20 to 24%, and generally 2 to 4% of population have neuropathic pain. If you look at the distribution of neuropathic pain from our head down to the toes, head and neck, trigeminal neuralgia, dental distraction neuropathy. Upper limb, you can have neuropathic pain because of compression or irritation of the nerve at the neck level, or Pancoast tumor of the apex of the lung can give us neuropathic pain. Entrapment neuropathies. At the thoracic level, it could be post-operative neuralgia or post-thoracotomy neuropathic pain. Abdominal, it could be entrapment neuropathy. Lower back and lower limb, it could be radicular pain, myalgia parasthetica, pain, neuropathic pain due to amputation and cutting of the sciatic nerve, and other causes as described in this slide. Let us look at the etiology, pathophysiology, diagnosis, and management of neuropathic pain now. Etiology, different causes of neuropathic pain. We looked at the distribution from head to toe where all neuropathic pain can occur. Let us look at some of the causes. Surgery, trauma can cause neuropathic pain. Amputation, phantom limb pain, stump pain, complex regional pain syndrome. Compression and inflammation and ischemia can cause radicular pain. Vascular disease or ischemia can cause neuropathic pain. Metabolic conditions like diabetic neuropathy is very well known. Nutritional alcoholic neuropathy is very well known. Infection can cause neuropathic pain. Cancer, because of infiltration and inflammation of the nerves, can cause neuropathic pain. Chemotherapeutic medications can cause neuropathic pain. Immune mediated like multiple sclerosis, and miscellaneous like Guillain-Barré syndrome. So these are some of the causes of neuropathic pain. If we understand the distribution from head to toe and probable causes of neuropathic pain, I think we can suspect where the pain is, which area of the body the pain is, and think if the neuropathic pain can occur in these distributions or area of the body. That's the reason I've looked at the area of the body as well as the causes of pain, so that it gives you some idea to consider neuropathic pain when you're assessing these patients. Pathophysiology of chronic and neuropathic pain, it could be peripheral or central. Generally, inflammation of a nerve, if a disc is prolapsing or nucleus pulposus leaking, irritating the nerve, that can lead to neuropathic radicular pain. Ischemia can lead to neuropathic pain when there is fibrosis due to operation in the lower back. Injury to a nerve is the most important thing in my opinion. Now, injury to a nerve can cause neuroma, that can cause neuropathic pain. Injury to a nerve can cause spontaneous firing of the nerve, that can cause neuropathic pain. Injury to a nerve can cause demyelination, and that can cause neuropathic pain. Injury to a nerve can cause reorganization in the system, wherein the fibers which normally carry tension pressure can make connections to the superficial layers where in the substantia gelatinosa, where there are cell bodies which carry pain messages. And because of this reorganization, the normal touch sensation can become pain. That's one explanation for allodynia. And nerve injury can also decrease central inhibition from below how much inhibition occurs at the spinal cord level. That means more information goes to the brain, and nerve injury can lead to loss of interneurons, which secrete inhibitory interneurons, which secrete GABA and glycine, which are inhibitor neurotransmitters. That can lead to increased pulse impulses going into the brain. Central causes could be central sensitization because of poorly treated pain. Central reorganization can occur. Decreased inhibitory control, as I said already. Neosympathetic innervation of the sympathetic nervous system along the nervous system, along the peripheral pain-carrying message pathways, can lead to neuropathic pain. Injury to a nerve cell body or axon, like in, say, for example, post-stroke pain, that can also lead to neuropathic pain. We very well know that if a patient has stroke, that can lead to significant pain, which can be neuropathic in character. So peripheral mechanisms, central mechanisms, these are proposed mechanisms of neuropathic pain, although it's not very well understood how much each of them can contribute. There can be more than this as well, which we don't understand. Diagnosing neuropathic pain is extremely important. I will discuss briefly about the clinical symptoms, signs, and response to pharmacotherapy. This is what I do in clinical practice. Look at the clinical symptoms, character of pain, burning, stabbing, shooting, stinging, radiating, piercing, lancinating, tearing, electric shock like. All characteristics of pain makes me think it could be neuropathic. Pain in an area of altered sensation makes me think it could be neuropathic. Pain in a numb area, diabetic neuropathy, the patient will say, the area is numb, but still I have pain in that area, diabetic neuropathy. Pain in the nerve root distribution in upper or lower limb makes you think it could be like C5 distribution or S1, L5 distribution in the lower limb, makes you think it could be neuropathic. Type of pain that patient has not experienced before, something different, this is completely different pain. That also makes you think that it could be neuropathic. So various ways of finding out if the pain could be neuropathic. Then you come to clinical signs, allodynia, that is pain, touch becoming painful, hyperalgesia, dysesthesia, nerve stretch sign, like you call straight legalizing sign producing radicular pain. So look at clinical signs as well. Despite all these things and being careful, still sometimes you have a doubt whether this patient has neuropathic pain or not. In such patients, we try a trial of pharmacotherapy of anti-neuropathic pain medications and see if it helps. So having multiple layers of assessing and finding out if the patient has neuropathic pain can be very helpful in diagnosing neuropathic pain, which can be quite difficult in some patients. Now, to substantiate what I've told just now, that it can be difficult to differentiate neuropathic pain from nociceptive pain in some patients, look at low back pain and radicular pain, lower limb radicular pain. The patients can have low back pain, and there could be referred pain in the lower limb up to the ankle area. How do you differentiate if it is neuropathic or nociceptive? Now, let me take nociceptive lower limb pain. The pain is generally aching in character. It is not associated with tingling, burning, shooting, or numbness in the area of the pain. Generally limited to the lower back and buttock area, but if the pain intensity increases, it can spread gradually down the back of the thigh or the anterolateral aspect of the thigh up to the knee joint level. Generally, it is up to the knee joint level. But in some circumstances, when the pain is quite bad, it can go to the calf muscle and ankle area. But always it will have that pattern that if the pain is not too bad, it remains in the lower back. As it increases, it gradually descends, generally above the knee joint level, but in some cases it can go up to the ankle area, but it's never shooting. That's what you need to understand. These are all examples of referred pain you can see in the lower back, going down to the back of the thigh up to the knee level. In some patients, as I said, it can go up to the ankle level, but you can see there's a broad area. Only when the back pain gets worse, then only it goes down. Or you can have a distribution where you can see there's a back pain and there is an ankle, pain in the calf muscle area up to the ankle. But if the back pain is not severe, they will not have the lower limb pain. And there are studies to prove this distribution pattern for nociceptive pain or referred pain, not neuropathic radicular pain. Whereas neuropathic pain, generally shooting in character, associated with tingling, burning, shooting, numbness in the area of pain, not limited to the lower back and buttock area, but shoots down in a band-like manner below the knee joint level into the foot. Generally, it goes down below the knee joint level into the foot, the dorsum of the foot or the sole of the foot. Spread and intensity of lower limb pain not related to the intensity of back pain. That's also important. Generally follows a nerve root distribution pattern in the lower limb. So if you look at that, that sounds like a neuropathic pain to me. You can see it's shooting down the lower limb and in a band-like fashion. So that's more likely to be a neuropathic pain in my opinion. Moving on, once we've understood the etiology, causes, and how to diagnose neuropathic pain, and say we have diagnosed the neuropathic pain, let us see how we can treat the neuropathic pain using pharmacotherapy, neural blockade, or stimulation therapy. NICE guidelines CG 173 suggested that if neuropathic pain is suspected, offer a choice of amitriptyline, duloxetine, gabapentin, or pregabalin. For trigeminal neuralgia, specifically it says carbamazepine. It also suggests consider tramadol only if acute rescue therapy is needed, while the above mentioned like amitriptyline or gabapentin are still taking effect. As you can understand, the tramadol has two different ways of working, like opioid, and some of its action is like amitriptyline. It inhibits the reuptake of serotonin and noradrenaline. That can also help neuropathic pain. Capsaicin cream for localized neuropathic pain in patients who wish to avoid or who cannot tolerate oral medication can be considered. Antidepressants, just be careful when you use antidepressants, tricyclic antidepressants for patients with irregular heartbeat, glaucoma, or prostate problem. Gabapentin, I normally start at low dose and then gradually increase the dose slowly and leave the patient to see how much they need and adjust the dose accordingly. Pregabalin also, I start at a low dose, say 50 milligrams twice a day, every 3 to 7 days. And I give the option to the patient how they want to increase every 3 days or 7 days. And if they're able to tolerate, say, 100 milligrams in the daytime, 150 gives them side effects, I tell them just stick to 100 milligrams. And if in the night, they may be able to tolerate more and go up to 250 or 300 milligrams. So the dose in the morning and night need not be the same. So it's always guide the patient to sort of adjust the dose based on the therapeutic response and the side effects. That's when they're going to comply with the medication. Advise the patients about dizziness, drowsiness, swelling of feet, weight gain, blurring of vision. Also advise them about driving. I always tell them that if you're taking such drugs, you will need to decide for yourself if you're fit enough to drive, especially the chances of altered reflexes will be higher when they increase the dose. And most importantly, ask them not to stop the medication suddenly, as this can lead to serious side effects. The medications have to be decreased very gradually under medical supervision, most important in my opinion. Topical preparations, capsaicin cream can be used. Lidocaine 5% plaster is licensed for use for post-traumatic neuralgia in the UK. Opioids, generally we don't use opioids for neuropathic pain because if you use opioids, you need high doses which will have significant side effects. So I have used opioids in very rare occasions where the patient has not responded very well to anti-neuropathic pain medications, in whom I've supplemented or added opioids in addition to the anti-neuropathic pain medications, very selected group of patients, but generally opioids are not recommended for neuropathic pain, but very selected group of patients, it can be considered. Combo therapy is important. This study looked at either using a monotherapy or combination therapy of duloxetine and pregabalin. And what it found was a combo therapy was more effective with lesser side effects. Just as an example, if say, for example, you started a patient on amitriptyline, 25 milligrams, the patient has tolerated, cannot take more than that because of side effects. And amitriptyline at 25 milligrams say, has helped the pain by about 30% or so. Then you add gabapentin, not delete amitriptyline and add gabapentin. You add gabapentin to amitriptyline and see if increase the dose to a tolerable level, if the pain relief improves to 50 or 60 or 70% or more, and then continue with that, and then think about any other therapy if the patient needs more pain relief. That's what we talk about combination therapy. And to build on the combination therapy, let me discuss about combination multimodal therapy. I think this is very important, and you need to have a mechanism by which you explain this to the patient also. What I mean to say that is, first, explain the patient what the cause of neuropathic could be, pain could be, explain the MRI scan images, refer them to physiotherapy when they can do it, tell them realistic assurance, give them realistic assurance, empathy, guide them to relaxation and mindfulness. So look at the psychological aspects of pain and address that as well. Then look at pharmacotherapy, add amitriptyline first, then add gabapentin or pregabalin. So sequential combination therapy is important, start low and go slow. And tell the patient to adjust the dose based on the side effects and therapeutic response. Some patients may say, well, I don't want to take the medications because of side effects. Then tell them what are the side effects of pain, disability, mood changes, depression, inability to go out. And then look at the side effects of the medications and ask them to balance. Then they will come to a conclusion, well, it might be reasonable to take medications at the moment to control pain, to decrease disability and distress. And once the pain gets better, we can always decrease the dose of medications and come off it. So educate them how to sort of use the medications in the right way based on the therapeutic effects and the side effects, and guide them what is best for them. Then consider interventions and explain the role of interventions to them and what they can and what they cannot do. One way of explaining and making the patient understand is by using some metaphors. So what I'm trying to get to them is that using combination of several things, the total pain control can be quite effective with less side effects. That is the concept you have to get into the patient's mind. And then once the patient understands, whatever you do is going to work better. That's my personal experience. Interventions, if you look at trigeminal interventions, balloon compression, microvascular decompression, or even radiofrequency denervation can be used. For upper and lower limb radicular pain, epidural and disc procedures, and in some cases, neuromodulation can be included. Now, let us take an example of low back pain or radicular pain. 45-year-old male with low back pain and pain shooting down the right lower limb in L5 and S1 distribution for about 6 weeks. MRI shows disc prolapse involving L5 and S1 nerve root. Management till now, we've explained the patients, the MRI results, referred to physiotherapy, psychology. Analgesic-wise, patient is on paracetamol, gabapentin, and amitriptyline. As I said, multimodal or combination or sequential therapy here. Ongoing physio, and the pain is better, 50% better, but the patient wants something more doing. In that patient, I think the NICE guidelines 2016 comes into play, which does recommend that in these patients, an epidural injection could be warranted. Now, when a patient gets radicular pain, it's generally because of inflammation or ischemia of the nerve root. There are lots of chemicals that are irritating, and putting localized steroid decreases the inflammation and buys the body some time to heal itself. That's what we're doing. So targeted interlaminar epidural could be helpful, or transforaminal epidural is more effective. It's surgery sparing and works in a good number of patients with good evidence there. And also more recently, there was a trial published, NERVES trial in Lancet, which suggested that in patients who have 6 months to 12 months duration of neuropathic radicular pain or sciatic pain, transforaminal epidural could be quite cost effective. Having said that, that should be the first line therapy, that's what it says, but still some patients are likely to need surgery. That's the technique of transforaminal epidural, where you come from the side and inject into the epidural space. This nucleoplasty can also be considered in selected group of patients where the disc is contained. Neuromodulation, of course, in patients who have had surgery before, there is fibrosis, and you've tried all the simple techniques to help with relieving pain. If it doesn't help, then neuromodulation could be considered. There is reasonable evidence to suggest that it can help a good number of patients. Prevention of neuropathic pain is equally important. Prophylactic preoperative neuropathic treatment in some high-risk surgeries like breast surgery, thoracic surgery, foot and ankle and hand surgery, there's some evidence for this. Treat acute pain optimally. Perioperative neural blockade can be very helpful. Avoid nerve trauma. I think this is the most important thing. Avoid nerve trauma is the most important. And if at all neuropathic pain occurs, treat early. These are some guidelines published by us. I've shared these guidelines published by the Faculty of Pain Medicine and the British Pain Society. They're available on the Faculty of Pain Medicine website. We've discussed the examples of neuropathic pain, etiology and causes of neuropathic pain, pathophysiology and mechanisms of neuropathic pain, how to diagnose neuropathic pain based on clinical assessment and drug trial. And then we discussed the management, including pharmacotherapy, psychology, physiotherapy, reassurance, and interventions. And we've also discussed how to prevent neuropathic pain in a given patient. Thank you very much.
Thanks to Dr. Sanjeeva Gupta for an informative talk. Our next speaker is Dr. Irfan Suleiman. He is an associate professor at Johns Hopkins University. He is actually medical director of pain rehabilitation program and is the founding director of pediatric interventional pain medicine. So please.
First of all, thank you so much for giving me this opportunity to be a part of this conference. It's a great honor for me and opportunity to present pediatric chronic pain management, which is a very rare service across the world. And unfortunately, because of this lack of service, our kids are suffer. And I'm hoping with this orientation of, due to this presentation, you guys will seriously think about it too and have some develop a pediatric chronic pain service. Objectives, no disclosure, and the objectives understand the pain mechanism. I will touch it briefly and also talk about the multidisciplinary pediatric pain program model, which I have in Johns Hopkins and the Kennedy Krieger. And also we will talk about the appropriate pediatric intervention pain management. So we are aware of this definition. It's the unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So let's talk about the quickly pain mechanism. So anytime when any kids or adult, they have any injury, so there is some chemical mediator released at the site of the injury and causes inflammation. And because of this inflammation or chemical mediator, the nerve ending and pain receptor gets synthesized. And most of the time in the acute pain setting, the healing process start, and they take few days to week, and then the inflammation get better and the signals turn off. Unfortunately, in some situation where this inflammation persists or the intensity of the pain is so intense that they and causing a persistence of pain, and that can causing central sensitization of the neuroreceptors or the pathway. So when this receptor gets sensitized, that not only end here, it continues to causing a central sensitization at the dorsal horn, and this continue and go to the higher center of somatosensory cortex. With this slide, one important thing I want to show here, when these pain signals go to the somatosensory cortex, at the same time, these signals passing through the limbic system. And when these signals persistent for a few months, as the definition of the chronic pain is pain more than 3 months. So imagine 3 months persistent, these signals going into the limbic system. So that change emotions, like patient can start having some anxiety or start having some depression. So this is an important thing to understand, that in the chronic pain, most of the time, especially in the pediatric pain, they have some emotional issues going on. So that's very, very important to identify and treat simultaneously. So when the pain signals go to the higher center, and then in response to that, the descending neuron originate from the brainstem release endogenous opioids that bind to the opioid receptor in the dorsal horn to stop the pain signals. So this is a normal mechanism, and nature built this mechanism, and patients start feeling better when this endogenous opioid release. But the purpose of showing this slide is, you can see, is not the only opioids receptor. There's some other receptor which also can stop the pain signals. So GABA and the GABA receptors plus clonidine receptors, serotonin, and TCA. So it's very important to not the opioids is the only way to stop the pain, but there is some other medication, a non-opioids medication can also stop the medication. So just thinking about to control the pain with the opioids is actually not a good idea. So yes, for the acute pain setting, post-operative, perioperative is okay to use the opioid for short term, but for the chronic pain, it's not a good idea to continue the opioid for long term. So anytime when any kids have an injury, we call it acute pain, and usually it takes few days to weeks, and in the normal healing process, the pain, after healing process, the pain signals turn off. And in some situation, intensity of depend on the intensity of the pain and duration of the pain. Sometime during the healing process, there is some plasticity or the neural changes occur. And when the neural changes occur, patients start develop a hypergesia and the anhedonia, and then we call it the chronic pain. This is another way to understand. So in the normal situation, when anyone have some burn or injury, they feel pain, and that's a normal thing. And if someone touch, they feel soft touch, so they feel touch. That's normal thing. But when the patient develop a central sensitization, so in the central sensitization, and that pain, which normally anyone can feel a 3 or 4, that patient might be feeling more than 10 out of 10 pain. And in an anhedonia situation, due to the central sensitization, when even you are touching soft, there's 0 pain, but it's just feeling of touch. But in the patient, when they develop a central sensitization, they feel like a 10 out of 10. The example is a complex regional pain syndrome and the AMPS. So what is a central sensitization? The central sensitization is, in addition to the activity-dependent synaptic plasticity, which we just discussed, change in the microglia, astrocytes, gap junction, membrane excitability, and the gene transcription all can contribute to the maintenance of central sensitization. And we can understand this by this slide, that anytime when they have an injury, there is a glial cell, non-neural cell around the nerve, which get also inflamed. And because of that inflammation, or because of this cytokines release, that make the nerve hypersensitive. That not only on the peripheral nerve level, but it's also on the dorsal horn, and it's keep going up. And in the dorsal horn is also activate microglia and astrocyte, and that's release catecholamines, and that make the nervous system hypersensitive, and we call it the central sensitization. So once they develop the central sensitization, then it's usually take time to reverse, but the good thing is reversible. This is a very important slide of my all presentation. Here you can see normal pain response. When anyone have this much stimulus, so they feel a pain. So this is normal mechanism or normal response. And in situation where the patient develop a chronic pain or the central sensitization, so this actually graph moved to the left. And because moved to the left, now with the minimum stimulus, he feel or she feel the same level of the pain. So this is a situation when the patient is in a chronic pain. So what we're trying to do when we are managing chronic, we are trying to bring this graph back to the normal life. So it's not a thing that you can do in a few days or a couple of weeks, but it's usually takes some time because that's a multi-modular approach that need a multidisciplinary approach to bring this back graph to the normal. So in Johns Hopkins and Kennedy Trigger, we built this about 6.5 years ago, this pediatric pain rehab program. And in this program, we approach with the biopsychosocial approach. Treatment of chronic pain only with the biological or physical pain is not effective. Like if I'm saying I'm a pain physician and I can handle the pediatric chronic pain, it's not right thing because most of the time they have some psychosocial issues. So that also need to be identified and also needs to be treated. For that, we need a multidisciplinary team. So when I say the multidisciplinary team, so in this program, we have in the multidisciplinary program, we have a multidisciplinary pediatric pain clinic, and we also have outpatient therapy. We have a rehabilitation day program, inpatient rehab, and the chronic intervention. In the multidisciplinary pediatric pain clinic, this is a frontline team, and that team consists of pain physicians, child psychiatrists, child psychologists, physical therapists, nurse practitioners, social worker, and the nurse. So we divided our group in 2 teams. Team 1 is the physical therapy and the pain physician, and the team 2 is a psychologist, psychiatrist, and the social worker. Each team spent 1 hour, and then we focus, try to do a detailed history examination and try to look into all the biopsychosocial influence which causing and amplify the pain. And also we look into what is the impact of his life, like if he's going to school, is the social life impact, is sleep effective, is not participating in sport, how the family dynamics and all these things. So that is a way we evaluate the patient. So the best thing is in our team approach or multidisciplinary, we are sitting on one table. We are under one roof. We see the patient together, and then we sit down on one table and discuss the whole case and get the input from all the experts. Once we have a input from all experts, we come to the conclusion that what's going on with the patient and what's the best treatment plan for this patient. Once we have the plan, then we will go back to as a whole team and discuss with the family and the patient that what's going on and how we're gonna treat this patient. So this is, you might have not seen this big team for this long time of, for long 3 to 4 hours. So this is one of the unique things that we have in our program. And I feel that 99% is very satisfactory by the patient and the family because they have seen other physicians who don't spend more than 15 to 30 minutes and the patient feel that they don't know what's going on with the patient. And with this, with time and with the whole team, most of the families and the patient are very satisfied. Okay, this team knows what's going on with me. And then that's the way we build a bond between the patient and the providers. And then once they have a bond and they trust us, then they follow our recommendations, and that helps to treat the patient. So we say that narcotics is not a good choice for the pediatric chronic pain. And so if we are not doing a narcotic for pediatric chronic pain, so then how we treat? Yes, we do a non-narcotic pain medications. And in the non-narcotic pain medication, we use a Tylenol and NSAIDs, anti-inflammatory medication. We use anticonvulsants like gabapentin, carbamazepine, and Lyrica. We also use SSRIs and tricyclic antidepressant, and also use lidocaine patches and diclofenac patches for if there's a musculoskeletal pain issues. So another important thing is the education. Yes, after seeing a patient, when we go back as a whole team, we spend 30 to 45 minutes more to explain what is a chronic pain and how we're going to deal it. So this is very important thing to educate the patient and the family, and that helps a lot. And because all the kids and the parents, when their kids in pain, they become anxious. But when they understand what's going on with this patient, and there is no harmful thing, and there's no damage ongoing damage, and this is just because of the central sensitization, so that significantly help us to manage this patient. Other than that, we also offer a physical therapy, land therapy, pool therapy. We also strongly believe on the behavior psychology, cognitive behavior therapy, and the biofeedback. And also we do a neuropsychology evaluation if we think there is a cognitive issue going on, and if we find something medical related issue, then we do a medical follow-ups. Intensive day program, which is a very unique program if the patient is failed outpatient program, and usually the physical therapy and the behavior psychology once a week. But if they don't respond, then we do an intensive rehab program. The intensive day program is like the patient is come every day for 5 days a week, and we do 3 to 4 week intensive everyday physical therapy, occupation therapy, and the daily behavior psychology, breathing techniques, and the pain coping skills. Also, we do some group therapy because they are enrolled with our program for 3 to 4 weeks. So we don't want them to be behind the school. So we contact to the school and get the syllabus, and we try to spend 1 to 2 hours for the school so they are not behind. In some situation where the patient is out of the state, they cannot come every day, or they have a significant disability, or they cannot walk, or it's not convenient for them to come every day, then we have an inpatient rehabilitation center where we admit the patient for 4 to 6 weeks, and we do the same thing, daily PT, OT, behavior psychology, and we also involved in some therapeutic recreational activity. Child life is also involved. And sometimes if the patient has some anxiety, depression, so we consult the psychiatrist to adjust the medication or start the medication to help anxiety and depression so they can get better or they can have good outcomes. Also, we have a peds medicine and the peds PM&R physician who are available and for consultations. The other thing is pediatric intervention pain service. This is also a very unique. And when I mention anyone that pediatric intervention service, so they talk about what kind of injections you do in the pediatrics. So we do all kind of injections that the adult, but the reasons is different because old age, they have a mostly degenerative changes, but in the young adults or the kids, mostly they have a same injury, but this is because of like a sports related injury. So they have an epidural steroid injection or disc herniation. They have a facet joints issues, SI joints issue, piriformis with the cheerleaders and the dancers. And also we do muscles or joints injection, occipital nerve block, abdominal blocks, intercostal blocks. So we do all kinds of blocks. But the important thing is because these kids are in pain, they are very anxious. Most of the adult world, adult pain world, they do the injections awake. So when you are dealing with kids, so these already are very in pain, and the area where we're going to inject is very hypersensitive. And so, and plus they're not going to be tolerate this weight injections, and they're going to move that can cause further complication. So the important thing is, I feel like this injection is more safer or better to do under sedation, or like we do a propofol infusion and we involve the anesthesia, bring the patient in the OR, and we under propofol sedation make them sedated, deep sedation, and so they don't feel the middle pain. And once, and also we make sure with all these things, so we really wanted to have this injection work, and we never do a blind procedure. We always use the ultrasound and fluoro guided injections. So this is all about from my short presentation. So I'm very happy to take questions. Thank you.
So thank you, Dr. Irfan Salman. After an informative talk from Dr. Irfan Salman, we have our next speaker, Dr. Atikur Rahman Ghafoor. He's consultant and pain medicine at National Defense Hospital. He did his fellowship from Ireland. He has vast experience in chronic and cancer pain management. He will be talking about developing an academic pain management unit in Pakistan.
Assalamu alaikum and very good afternoon. Thank you for having me here. So I have been organizing this session for last 5 years. So it's the first time I'm coming as a guest. So it's feeling a little strange. So hum jo thehre ajnabi itni madaraton ke baad. So coming to the topic, every year the Shaukat Khanum organizes a symposium and we do have a poster for it. So this time if you see the poster, that's in the just corner pe dekhe right side pe Shah Jahan Mosque. So I tried to search like what the Mughals have contributed to the medicine, especially to the pain there. So I think Dr. Morarity is not here, so I can like be okay with the Urdu. So I tried to see what the Mughals have contributed to the medicine. So actually couldn't find anything there like so, but they have a huge contribution to the science of the architecture there. So you guys know about the Taj Mahal that the Shah Jahan built out of love for his wife. And then a couple of other buildings, Red Fort and Masjid Wazir Khan in Lahore, and then the Shalimar Bagh. So our foreign delegates can go around and just have a visit these places. So coming back to the topic, in the program it's written I am working in the National Hospital. So I do work in the Evercare Hospital and I work as a kind of advisor for a couple of other hospitals. I'm a member for the faculty of the CPSP in pain medicine, but I'm not here on the behalf of the College of Physicians and Surgeons, Pakistan. And the other thing to disclose here is it's a non-academic talk. So only one thing is academic here, that's the title. Okay. So coming to the pain medicine, John Bonica, he's the founder of the pain medicine. This guy, American anesthesiologist and a wrestler, he came back from the Second World War, and they're trying to explore like what's going on wrong with the soldiers here with the chronic pain, and there's a poor service there for them. So he started the clinics there, and then he founded later on the International Association for the Study of the Pain. So coming to the Pakistan, Brigadier Salim, many of you know him. He started the first pain clinic in Pakistan in late 70s, and then he founded the Pakistan Society for the Study of Pain in 1980. And later on, this society became Society for the Study of Treatment, Study and the Treatment for the Pain there. So coming to the Lahore, Professor Khalid Bashir is the guy who first started the clinic in Lahore in Services Hospital, and then he established the faculty as well there. So a typical academic unit would be having kind of teaching, training, research, and the service provision there. So teaching is not only the stuff we already know. So it's about making you how to practice it in a safer way. At the same time, any academic unit will provide you an opportunity where you can explore your ideas and contribute to the evidence there. And at the end, this all will translate into evidence-based service provision to a person, to a society, and to a country there. And that's what we are looking forward and we're going to talk about. So working in Pakistan, a SWOT is a brief way to analyze anything there. It's being used since 1960s. So if you look in Pakistan, so what are the strengths, weaknesses, opportunities, and the threats there? So, you know, like it's a in 30th ranking area-wise, 5th most populous country. So it's not itself the 222 220 million people, like that's our strength. So it's a young population there. More than 35% here are less than 15 years of age. So that's the population we can really work on in relation to the academics there. If you look at the weaknesses, lack of good governance and the sustainable development, opportunities wise, there are gaps in every area. So in institutions, hospitals, in any area like, so there's huge opportunity to contribute there. That's why it's always there is political uncertainty and economic downturn there. So particularly talking about the challenges in the pain medicine. So I have divided them in a way like denial by peers and then the contribution by the managers and then come to the patient here. So if you look at the peers, there is a lack of awareness about the pain medicine. So I will just quote a survey here that's very interesting that was done by the Khanum University Hospital back in 2013. So they did in Karachi, like, and they've gone to the various GP clinics, and what they have found there, more than 50% have no idea like who look after the pain medicine. We are talking about the Karachi, we are not talking about some remote city there. And most of them think like it's orthopedic surgeon, neurologist, or maybe the family pain physician. And more than 85% have no idea about the modern pain medication. So that's awareness among the peers there. So they have no idea it's an existing specialty, or maybe there are doctors or specialists who can look after this problem. So if you look at the interspecialty prejudice at the part of the peers there, so you know yourself, everybody says like pain is a symptom that anybody can look after as a doctor there. So especially in the developing world, there is no culture of referring the patients to the area where they can be looked after very well. So if you come to the managers, so they think like it's not a disease. It's a symptom. So once you have the pain clinic, then they're going to diarrhea clinic, headache clinic, or blah, blah, blah. So there will be a long list there. So either you stop the advocacy for your pain or you just quit. Coming to the patients, obviously there's lack of awareness. So if your peers don't know, your managers don't know, how the patient's going to know about it. At the same time, particularly talking about the developing world, there is a quackery. So everybody present themselves as a specialist of various areas. At the same time, cost is another issue there. So these are the kind of challenges, keeping the SWOT analysis in mind and the peers and your managers. So there are challenges there, and there is a survival for the fittest, you know. So I have just put this slide, some fish swim upstream. And why they swim upstream? They just want to keep their existence on the globe. For the reproduction, they go upstream. So we don't have to go upstream, but at least we can go along the stream and play our role there. So International Association for the Study of the Pain has contributed a lot, not particularly in subcontinent, but in this area as well. So there are 96 chapters, 19 in Asia. They have developed in 2002 developing countries working group. So training centers in Thailand, Colombia, South Africa. So they have given the grants for the pain education. Pakistan has received this grant for 3 times. Later on in 2008, they make a particular group who can liaise on with the government officials for the advocacy of the pain relief there. So coming to the Pakistan, qualifications are there. They are existing for long. Peers have really done a good work. MSc in pain education, pain medicine since 2005. Then Al Khan University Hospital has non-accredited pain fellowship program since 2005. And FCPS pain medicine started in 2014. Most of you are aware of this slide that you have to pass the FCPS anesthesia, then you get enrolled for the second FCPS in case of pain medicine. It's a 2-year training program, and then you take the exam there. So for any unit to get recognized for for any specialty, there are certain prerequisites from the College of Physicians and Surgeons Pakistan, and they're available on their site, or you can get it from the college there. So talking about the FCPS, it's a two years program. You have to do 1 paper there. Then you have to maintain obviously the E-log there. There are 5 rotations you have to go through: psychiatry, neurology, orthopedics, radiology, and also the physical rehab there. You go through the internal assessments and then the examination, and then you get the certification for an independent practitioner to work in the pain medicine. So at present, there are 8 approved centers nationally. 6 of them are in Punjab and 2 are in Sindh. Shaukat Khanum is really proud to be the first center in Lahore. And after that, the national board recognition, and then the Sheikh Zayed there. So currently in the national, we have 5 fellows. First 2, Sadaf and Hamza, inshallah, will be doing their exam in 2024. And they will be the first FCPS in Lahore, inshallah. So if you talk academic activity on part of the pain medicine there, SKM Symposium annual activity, very good session of anesthesia and pain medicine here. AKU every year hold a pain day, brilliant activity. STSP, Society for Study and Treatment of Pain, conduct pain cone every 2 years. This time it's going to be in Lahore. And again, STSP runs various workshops. So I'm really proud talking about these 2 projects. They really come under the heading pain academics. So we did the survey in 2021. It's the first of its own kind, national level. Dr. Amar really did one of in Shaukat Khanum. And the second study we completed in 2022. That's going to be today in the SN Sheet Memorial Award. And I'm really proud of what we did like during last 5 years. So why I put this slide here. So 5 years and 3 times we won this award, that's on the sheet. And twice it was the pain project. Not purely pain, but related to the pain there. So this time Dr. Asad Masood is presenting that CELIC study. So we are looking forward a few more hours, inshallah, and we'll have the award there. So before I finish, thank you very much. I know like I don't have everybody in the picture there. I wanna thank you them. Most of the residents, they have been like really on the front foot for everything what I've been doing. So, and at the same time, Irish faculty from the Ireland, they have played a brilliant role, like Dr. Declan O'Keefe was here, then Dr. Camillus Power and Hugh Gallagher, and today we have the Dr. Jane Moriarty. So despite the challenges, main thing is just to keep on focus, keep on playing the positive role, and just play your part for no more pain. Thank you very much.
Thank you, Dr. Teek. Our next speaker is Dr. Khwaja Shahryar Nasser. He is consultant and orofacial pain. He is an American board diplomat, and he will be talking about use of interventions in head and neck related cancer patients.
So thank you, Dr. Almas, for inviting me. I'm going to be talking about use of interventions in head and neck cancer pain. I'm sure at some point my slides will come up. Until they don't, you can see me. So I don't have any disclosures. So head and neck cancers, as we all know, these are a heterogeneous group of upper aerodigestive tract tumors. About 90% of these cancers are composed of squamous cell carcinoma or variants thereof. Squamous cell carcinoma, unfortunately, is a very aggressive, debilitating condition. And as you can see, the condition is associated with a lot of disability, debilitation, a lot of symptoms, a lot of destruction. And whenever there's destruction, it results in eventually pain there as well. I know we have talked about this. Some authors have touched this throughout the talks. But generally, when we talk about prevalence of cancer pain, overall, the prevalence is about 40%. However, in head and neck cancers, as we saw earlier as well, the prevalence goes up to 70%. But this doesn't end there. Unfortunately, in some cases, particularly advanced disease, patients that have tumor in tongue, floor of the mouth, prevalence can be about 90%. So coming back to management. Whenever we talk about management of cancer pain in head and neck cancers, I believe that there are 3 things that you need to worry about. Your plan should be directed towards what's the clinical phenotype. Second thing is that it should be delivered in a time contingent manner, not on as needed basis. And lastly, it should be driven by pain intensity. So whenever we talk about what are the things that need to be managed, basically you divide your management into 3 folds. There is pharmacotherapy, which we know a lot of people have already spoken about that. I'm not going to touch that. There are non-pharmacological interventions. You talk about physical therapy, occupational therapy, as well as biobehavior or behavior therapies. And then there are interventions, which we'll talk about in a bit. but generally almost 80% or so of your patients will actually get better on the modalities which are non-interventional, non-aggressive. These are usually your pharmacotherapy, that's your mainstay, and then non-pharmacological interventions as well. However, today we are going to talk about where I would do interventions and where I would suggest that you should do interventions as well. So I'm going to go over a few cases with you. This is a 39-year-old male patient that presented with tongue pain. Patient had history of squamous cell carcinoma tongue, previously treated by surgical resection. You can see the scar of the surgery on the left side as well. Unfortunately, patient had nodal metastasis, so he went with chemoradiation, then failed, then had recurrence, had multiple lines of chemotherapy, and now oncology clinic had suggested that patient should be on a break because of the declining functional health status. So when we asked about history of pain, patient reported that pain was originating from tongue and then radiating downwards and backwards bilaterally, going across the jaw into the ears as well as temporal area. Pain was constant, dull, burning in quality, but in between patient also had those shooting electric episodes of pain that were radiating bilaterally. Patient reported their pain was 10 out of 10 in intensity. On examination, unfortunately, you can see these pictures as well. You can see there's ulcer right in the center of the tongue with the fistula that is going inside the floor of the mouth. Everything that was palpated, masticatory muscles, the jawbone, anterior temporalis, middle temporalis, they were all tended to palpation. So patient at this point was already on quite a few medications. They were taking morphine, they were taking diclofenac, which is a non-steroidal. They were on pregabalin, acetaminophen or paracetamol, that's the same thing. And they were using a topical anesthetic, lidocaine mouthwash 2% after every 2 hours. And unfortunately, this regimen was still providing this patient only 40 to 50% relief in symptoms. So if I see someone like this in my clinic, I feel that at this point, we need to do some sort of intervention. The easiest intervention or the basic intervention that I can do for them is something that I actually do on the chair side. Before I go into that, one thing that I think we should all establish here is that patients' pain's clinical characteristics resemble what we call trigeminal neuralgia. There is some burning mouth characteristics there as well. So these two typical phenotypes are for what we call neuropathic pain. So what we did for him was that we did bilateral mandibular division block, and we also blocked their cervical plexus. So we did a superficial cervical plexus block. And when we did both of these, patient had immediate pain relief. This absolute pain relief persisted for 2 days, which is something that we shouldn't expect because these blocks just work for a few hours. And then patient had 90% or more relief with medications, which he was already on. We didn't change those. And that relief lasted for up to 5 weeks. And we had to repeat those again. And patient was quite happy with the progress. So what are nerve blocks? Nerve blocks are basically, everyone knows this. This is a basic technique where you inject a local anesthetic along a nerve or around the nerve. And what it does is it causes inhibition of sodium channels that doesn't allow these conduction to take place. So I already talked a little bit about these indications. So indications for block would be that patient should have a neuropathic-like pain. Pain should be severe. That is about 7 or more out of 0 to 10 scale. And sometimes I would also suggest that these should work really well for breakthrough pains. When I say breakthrough, I mean 2 scenarios. One is that patient is doing really well. For example, this patient, imagine that was doing really well, had no issues whatsoever, but suddenly the pain got really bad. That's when you should do intervention. Or patients, most of the day, the patient is actually having pretty good pain relief, but every now and then they'll have a spike, which causes them to have a lot of distress, debilitation, causes them to stop their activities. Maybe that's the time where you can actually also benefit by doing a block. So how effective are these? Unfortunately, in head and neck cancer and head and neck cancer related pain, the evidence in the literature is quite low and poor. Actually, there isn't one. It's very minimal. So we have whatever evidence I'm going to show you is what we have sort of gathered. So I am presenting some of the evidence from the studies that we have done, unfortunately, because there isn't anything else to compare with. So we found out that almost 80% or so patients had absolute relief for at least 2 days post-intervention. But this drops down to 60% after a month. The good thing is the ones that actually do get benefit, the relief remains almost for 6 weeks, which is pretty good in this case. And we are able to somewhat predict who is going to get better and who's not. And somehow amitriptyline works really well as a predictor. So patients who are using some sort of medication, such as a tricyclic antidepressant, amitriptyline, they tend to have a much better response compared to those that were not on it. One possible hypothesis that I have is that because amitriptyline has really good both neuropathic as well as musculoskeletal properties, at the same time it has an NMDA receptor antagonist activities, which we saw earlier as well. I'm not going to go into a lot of details, but we talked about central sensitization, peripheral sensitization. So this medicine works really well in those cases. So maybe it's because of that. The intervention does come with side effects. The good thing about this is that these are infrequent, and because they are associated with the block itself. So because of that, they actually just last for a few minutes to a couple of minutes and then go away. So most commonly, depending where you are injecting, obviously, dizziness is something that I feel that patients complain the most of, or lightheadedness, if you want to call that. Whenever you're going to be injecting around the parotid gland area, because the cutaneous branches of facial nerve come through this area, so there'll always be facial palsy. Sometimes it can actually result in worsening of pain. That can always happen. And then few of the occasions, patients do complain of injection site soreness. This is particularly true for injections which are more superficial. So let's go on to another case. This is a 34-year-old female that I saw because she was complaining of spasms associated with regional pain that had been going on for weeks. Medical history of this patient was significant for adenoid carcinoma. This was initially treated with surgical resection of the parotid gland, but patient had recurrence. And after that, the recurrence was in the temporal and infratemporal area. Patient was reporting of spasms in the jawbone as well as sternocleidomastoid muscle, and it was associated with severe shooting pain. In addition, she had this generalized ache in the area, which was associated with more tightness in this region. So examination, as you all saw, there was a mass present on the right temporoparietal area. It was soft but tended to palpate. But then these two areas, I think you can actually see this on the picture as well, that these are slightly raised. That is where the patient was actually getting those spasms. These muscles will get really tight and patient will have a lot of pain in this area. This lady was already on quite a few medications when I saw her. She was taking tramadol, she was taking acetaminophen, she was taking celecoxib. She was on 2 different types of muscle relaxants here, amitriptyline as well as tizanidine. We could not titrate her medications because she had a very low weight. She was in early 30s kgs weight. Whatever other medications we tried on her, like diazepam, she couldn't tolerate them. She had a lot of somnolence and dizziness associated with that. So at this point, where we have already tried muscle relaxants to calm these muscles down and to confirm whether this is the area where the patient is actually complaining the pain from, what you can do is that you can actually do simple trigger point injections. These are directed right into the muscle, which you feel are the ones that are involved. So in this case, we injected her in masseter muscle as well as sternocleidomastoid muscle. And certainly patient had significant relief in symptoms. Whenever I'm going to use word significant, by that I mean 75% or more reduction in the baseline pain. So trigger point injections are basically a local anesthetic injection that is administered right into the skeletal muscle. Indications are pretty much similar to what I told you about, what I talked about neuropathic pain. However, in this case, we are looking at musculoskeletal pain, more dull, tightness, descriptors of pain, spasms. Those are the descriptors for musculoskeletal issues. And then similar to that, same thing, severe pain, breakthrough episodes of pain. There is no data that I know of that has been established on effectiveness of trigger point injections for head and neck cancers. But I can tell you for non-cancerous pain, the data is very similar to that for the neuropathic pain blocks that we saw earlier, that it works for in about 70% of cases, and patient may have relief for up to 8 weeks. Side effects also are very similar to those of nerve blocks, But in this case, as you can see, there is bruising there as well, because when you are injecting with the needle, and since these muscles are more superficial and they're very thin and small, it's more likely that because of that injection area, depending on what size needle you're using, you are going to get some sort of bruising in the area. People who have lighter complexion are more likely to have this compared to dark-skinned people, or you might actually not be able to notice that. So particularly those who have beard like mine. But either way, if you use a smaller needle, I use a 27 gauge needle, the likelihood of those do come down. But imagine you did this injection and patient did not have any relief. The relief lasted for less than 12 hours. That's usual time for local anesthesia to wear off. What would you do? If you do get into this conundrum, one thing that works really well is botulinum toxin, which most of you do know that people use for aesthetic reasons, but it's actually also used for management of multiple painful conditions. In our case, in this particular scenario, the indications would be that pain that is not responding to any interventions that you already tried, like simple blocks and muscle spasms. It works as far as effectiveness is concerned in about 70% of the cases. The reason I've written effectiveness is because here the definition of effectiveness is at least 25% reduction in pain, not 75. If you increase the benchmark, the effectiveness goes down to about 35%. But it works really well for muscle spasms. The thing to look for is that the relief will not come in immediately post-injections. It's going to actually be very slow. So it's going to take up to 2 weeks. The maximum benefit is around week 6. But then after week 10 or so, it starts to go down. So it's a 3-month cycle that you have to look for. If it's going to work, it's going to work like that. The other thing, particularly working in Pakistan or any other low middle income or low income country, is that these injections do cost a lot. Because botulinum toxin in Pakistan right now costs for about 44,000. It comes in a 100-unit vial. And I'll talk about that, why that is important in a bit. Actually, it's the next slide. So side effects are common, but again, because this particular ingredient that you are injecting actually gets broken down by the body itself. So whatever side effects are going to come up, they too are going to go away. But we do know from our different evidence of literature that if you are injecting about 40 units per muscle, you're going to be having much more side effects compared to if you're going to be going below this range. These particular side effects are because what happens is that the muscle actually undergoes paralysis. The muscle will actually undergo atrophy. Whenever that's going to happen, what's going to happen? If you are injecting in the aesthetic zones, you are going to have some deformity. If you are injecting only on one side of the face, you are going to have thinning of face on one side and the other side is going to remain the same. And then sometimes post-injection, patient may complain of paresthesia, pain, injection site soreness, because this particular injection is given without local anesthesia. You are actually diluting botulinum toxin in saline rather than local anesthetic. And we can talk about more later on in question and answer session about this. Last case is on facial pain. I'm sorry for the images that I'm showing you, but unfortunately, this is the inherent nature of the disease. This is a patient who is 63-year-old, complained of left side face pain. Patient had squamous cell carcinoma of buccal mucosa that was treated surgical resection, had radiation therapy, then had multiple lines of chemotherapy, which did not help. And patient had been shifted to palliative medicine. And my colleagues who were sitting in the back referred this patient to me. This patient complained of pain that was originating in this area. I can't say it was buccal area because that's no longer there. And then was radiating into the regional tissue, going up into the head and going backwards. Patient was saying that this pain has qualities of being burning, electric, and dull. Pain intensity, as you can imagine, was 10 on 10. Clinically, I don't know if you can appreciate this or not, but you can actually see patient's maxillary sinus. You can see the mandibular bone, whatever is left of tongue, soft tissue, and you can also see lateral pterygoid plates as well. Patient was already on morphine 60 milligrams, acetaminophen, celecoxib, amitriptyline, pregabalin, but was having relief for about 4 hours. So we did injections. which we think would have worked for him. But they just gave him relief for about 6 hours, and then patient again had the same level of pain that they were having before. So at this point, it gives me two things. So one thing is that if you are able to get their pain levels down, that means that you are in the right area. You do know that these are the nerves that are acting up. So maybe we need to do something which actually lasts longer than 6 hours. And in that case, the answer is neurolysis. I particularly use chemical neurolysis for my health, myself. I use phenol 6%. And in this case, we had a significant relief in symptoms until patient expired after around week 6. So neurolysis, I know some of folks talked about that earlier as well. It's a technique that uses either heat, physical or chemical means to neuralize a nerve. This phenomena is actually reversible. And you can actually understand that because the evidence for that comes through your trigeminal neuralgia literature, where we inject these chemicals or we try to neuralize these nerves, and pain tends to come back after about 18 months, from actually 6 to 18 months. But in this case, if we are not expecting the patient, unfortunately, let me address that elephant in the room, to go beyond a couple of months. So in those particular cases, this modality works really well. The indication is that you have tried everything else and nothing is working, so that's when you're going to try this. I would not recommend it on patients who you expect that they're going to survive. I don't suggest this modality to be used in patients who are not expected to, who are expected to, live beyond 12 months. So effectiveness, as far as chemical neurolysis is concerned, it's significantly effective for about 85% of the patients. Again, one thing that you have to understand is that it's an adjunctive modality. It's not that once you're going to do this and patient will not require any medications. It will bring the pain levels down. It will improve their effectiveness of a medication. But at the end of the day, it is an adjunct. I couldn't find much literature for head and neck interventions for radiofrequency ablation that was just focusing on head and neck. But overall, it works really well. By now, you would have caught up. I've written statistically significant. Statistically significant means that it is able to at least bring pain level down by 1 notch, or more, whichever was valid, but was statistical. It doesn't mean it's clinically effective. But either way, it is an effective modality. But even if you include a clinically significant definition in there, I still expect the effectiveness of this modality to be between 85 to 90% as well. And that's what the literature tells us as well. Again, very similar outcomes of chemical neurolysis that you'll expect from radiofrequency ablation as well. Predictors are that patient should be on some sort of gabapentin or similar neuropathic medications, and earlier intervention. These tend to work really well for these patients, but again, it's a balance that you have to see, that if a patient is not going to be tolerating or is going to survive, then this might not be the right thing for them. Just to end my talk, side effects, these are going to be somewhat more permanent because you are injecting something that is actually not a very pleasant material, because it's going to be neuralizing the area. So it's going to be neuralizing whatever is in the surroundings as well. So nerve, the surrounding soft tissue, bone, fat, they all get neuralized. And because of that, you may actually end up having somewhat more side effects and more serious side effects than you would see in other interventions. That's it. Thank you so much.
Thank you, Dr. Shahriyar, for valuable talk. With this, we have question and answer session, and we have our speaker, Dr. Salman, Dr. Irfan Sulman with us. If you have any question, he will speak about it. So any question you want to do?
Thank you, Dr. Irfan, for being here.
I think your mic is off.
Thank you, Dr. Irfan, for being here. I think it's this pediatric chronic pain as a subspecialty of pain medicine is something which is very new concept for us. I just wonder how much in terms of evolution is there, and how did you manage to, because you're the founding director of this service in your hospital. So how much, like, did you evolve this service? Do you get people who are like specialized already in pediatric chronic pain? If they're taking on further, I would be asking the same question to Dr. Khalid Bashir, because he's the one who's started the entire chronic pain medicine in Pakistan. So I would be wondering if pediatric chronic pain has taken off in Pakistan or not. So first, Dr. Irfan, please.
Thank you so much again for giving me this opportunity to talk about, and I agree with you. The pediatric chronic pain is a very rare specialty, and especially even in the USA. So we are only few hospitals in the USA who provide this service. We are actually 2 of the 3 programs who are accredited fellowship, Boston Children's Hospital, where I train, and the Cincinnati Children's Hospital, where they have these fellowship and they train, and we are actually having our last 5-6 years, we have a improvement, like more center are interested and they are interested to build this program. When I was as a founding director, when I was trying to build this program, and I have an interview in different hospitals, and the big issue is finance, which is everywhere, even in Pakistan. So how are we going to generate the revenue, and is very time consuming. And I joined the Johns Hopkins because they are the leaders, and they think they want this service even they are in a loss. So that the thing attract to me, and then I joined Johns Hopkins and start this program. And so far, like, I think it's a pretty good program in a way. Like, even if in the loss, we are providing this service to the kids, and these kids, it's not like I've compared with the adult or cancer palliative care. These are the irreversible conditions. But these kids who having this pain is like by the sports injury. Most of them have a sports injury or post-operatively. If their pain is not well managed perioperatively, that's why I always suggest to my anesthesia resident to make sure you have a really, really good pain control during the perioperative or post-operative, because if their pain is not well controlled, then they have a high risk to develop the chronic pain, and they can develop a central sensitization. And these kids are like, imagine 10-year-old kid and who have a little bit like a injury while he was playing in the playground. And the experience of the pain he had, he gets scared. Because of that scaredness, he limit his activity, and he don't want to move, because when he move, he gonna have a same pain again. And that usually for just a few days, and afterward the injury is healed, but still the experience of the pain he had, he don't want to move. And unfortunately, the primary care providers or all of us and the family, parents, they also don't treat when they have acute pain. So like, kids say, oh, we don't want to, even the paracetamol or the ibuprofen, all these for the acute pain, they don't give it, because they say, oh, it might be gonna make addicted, or we don't want to give her, and they suffer. When they suffer, then they develop a central sensitization. So another thing is, I think this is the reason I give this talk in the SARC conference also, and I got opportunity, and I'm giving here, and I give a couple of talks in the Aga Khan Hospital. And I think the reason I'm giving continuously these talks, because I really wanted to have this program in Pakistan. Aga Khan is a little bit interested. I'm in touch with them, and we talk a few times. I hope they can able to, and they are seeing a few patients, adult pediatric patients with the adult, but they don't have a separate. So Dr. Khalid Bashir is here. So I think he's the leaders in pain, so he can think about it to build a program in Pakistan, and I will help anyway, like whatever needed, I will try to help them.
Thank you, Dr. Irfan, for comments. I would like to answer Dr. Khalid Bashir.
Sorry. So can you repeat your question?
Any comment about this session? And
all the session was wonderful. Yes. We discussed many things online and physically. Dr. Teague spoke good about, told us about teaching activities which have started, and College of Physician Surgeons has started second fellowship in anesthesiology, and we are all after it. Then Dr. Sharyar spoke very well, and I'm sure he's doing a wonderful job relieving pain in very difficult areas. So I'm thankful to all of you for being here and presenting a useful talk.
So with this, thanks everyone here in the session. I would like to conclude the session. Thank you.